interesting. Like the next lecture, when I get a chance to do how to manage acute right heart failure, right ventricular cardiogenic shock. I think that's very common in the hospital. There's a lot of misconceptions, a lot of unknown areas. I think that will be the next topic. So this one will be like overview of how we approach PAH, pulmonary arterial hypertension. So first thing is this does not apply to group 2 pulmonary hypertension, group 3 pulmonary hypertension, or chronic pulmonary model. Just take everything out of your mind. This is only for the special PAH, the category 1, the idiopathic group of scleroderma. Okay? I don't want you to transfer this data into a group 3 PAH or group 2 PAH. I think it's still, the water is not clear yet. I don't want you to get confused. Okay? This is mainly for PAH. Okay. Have a diagnosis now. So how do, once the patient is diagnosed with PAH, yesterday I saw a patient, just to give you a perspective, she's 62 years old, she has scleroderma, has been followed by a rheumatologist for many years. Now she's also having exertional shortness of breath. It is an echo, elevated right ventricular pressure, so they refer to us. It's a complete workup. Her PA pressures are 80 over 30 with a mean of 50. Her cardiac output is 5 with an index of 2.4. The PVR is 9. She has every other coefficient ruled out. Like group 2 is ruled out, group 3 is ruled out, group 4 is ruled out. So she's scleroderma PAH. So how would I treat such a patient? Okay. Just, the treatment of PAH involves general measures for management of your heart failure, right heart failure, diuretic, oxygen, and digoxin. Then, certain subset of patients will benefit from anticoagulation. I'll just go over who would benefit from that. And then we do. Sure. Can you hear me now better? So then, a subset of patients would benefit from anticoagulation. And then we do vasodilator therapy or anti-proliferative therapy. So these are pulmonary vasodilator therapy. If those therapies don't work, then the next step would be to go for a lung transplantation or a balloon interatrial septostomy. So we'll just go over what are all the evidence for this therapy, okay? Or these therapies, I have to say. So digoxin. So why do we use digoxin? Do we use it routinely? I pretty much use in most of the PAH patients if they have right ventricular failure. So their cardiac index is low, their right atrial pressure is high, their RV is dilated. I do an MRI. If their right ventricular EF is low, I start them on digoxin. It has inotropic effect. There is data to show that acutely in the cath lab, if you give digoxin, their right ventricular contractility improves. There is no long-term data like this trial on the left heart side, but on their acute data is there. Then based on clinical evidence, we use it. And it's intuitive, right? Nobody's going to do a trial on long-term digoxin. It's a very safe medicine. We have personally seen good response, like, both during my training and here. Oxygen, it's very, very important if they're hypoxic to correct hypoxemia. Why? Because hypoxia will cause pulmonary vasoconstriction. It's going to make your pulmonary pressures worse. It's going to make disease worse. So we don't want these patients to be hypoxic. How can they be hypoxic? There are a couple of ways why they can be hypoxic. If you have a pure PAH patient, they don't have any lung disease at all. It's the right ventricular failure. When the right ventricle fails and is not able to generate enough cardiac output, you're not getting enough oxygenation. Blood is not being oxygenated because it's not even going to the pulmonary circulation. Second is they can have a right to left shunting because 1 in 4 of us have PFO. So if you have a very high PA pressure, the right atrial pressure is going to be higher than your left-sided pressure. So they're going to shunt from the right side to the left side, right? The last reason is coexisting lung disease, because sometimes these scleroderma patients can have lung disease and they can be hypoxic from that. So we don't want them to be hypoxic. We don't tolerate any oxygen saturation less than 90%. We put them on oxygen.
You have to document that in PAH, Medicare only allows you to take below 88%. You have to document because you can get oxygen.
No, it's a good question. So we use it mainly for less than 88%, like, like 98, we say that. But what we do is we have to document, when we do a 6-minute walk test, we show them that desaturates. And then, like, we have to use oxygen 2 liters to show that that gets corrected. That's how insurance would approve. And PAH is an approved indication. They meet all these criteria. Okay, so next is anticoagulation. So majority, previously when I was trained or in 2000, most of these patients will get started on anticoagulation. There is no randomized controlled trial to guide, or this recommendation is not based on a randomized controlled trial. This is mainly based on a prospective study actually by one of my mentors, Stuart Ridge, during the 1990s. So as you can see, what he did was during the time 1990s, there was no treatment at all, mainly calcium channel blockers or Coumadin and supportive therapy. He took patients who were not calcium channel blocker responders, like current PAH non-responders. And then he gave them, some of them Coumadin, some not Coumadin. It's just a prospective observational study. When you match them, people who were treated with Coumadin had a much better survival than those who were not treated with Coumadin. What is the biological basis on which one would give Coumadin? In patients with pulmonary arterial hypertension, in the small blood vessels, in addition to the vascular remodeling, there is in situ thrombosis. So you can see here, this is actually a small resistant pulmonary artery. It's a 200 micron size, and you can see this red stain is all the thrombus. So there is in situ thrombus formation. And this has been shown in many patients with PAH. And the first one to describe this was Valentine Fuster, who was actually at Mayo Clinic at the time, and one of the patients died in their CCU. They did an autopsy and they showed thrombus all over. And from then, people have been anecdotally using Coumadin, and then this data came from Stuart Ridge in the 1990s. So pretty much then everybody started using Coumadin. Now, in the last 20 years, we have learned, and the INR goal is 1.5 to 2.5. Is it based on any data? No, it's just a consensus like the PH experts developed. In the last 20 years, we have accumulated so many data from many registries. There's a registry from Chicago where I trained. There's a REVEAL registry, which is a multi-center registry in the United States. And there's a French registry, and there's a German registry called Compare Registry. So people said, okay, this question has been unanswered. Let's go back and look at this question on Coumadin, whether Coumadin really helps. What they found out was really, I don't have the slides on it right now. It just recently published in Circulation, is patients with idiopathic PAH or familial PAH. Now we're talking in group 1. In group 1, there is idiopathic or familial or associated with connective tissue disease, portal hypertension. So of all these categories, only the idiopathic or familial people who actually got better. But when Stuart Ridge studied those patients, these are actually only idiopathic PAH. At that time, scleroderma was not even recognized as a risk factor for PAH at the time. So what it turns out is patients with idiopathic or familial or drug-induced PAH benefit from anticoagulation therapy. Those who have connective tissue disease or liver disease or HIV, they don't benefit significantly, and it may sometimes hurt them because connective tissue disease, scleroderma, they have AV malformations in their gut and they may bleed. So our practice has been lately, we give them Coumadin if it's a pure idiopathic PAH, and we go for a goal of 1.5 to 2.5. No need to bridge them with Lovenox if they're going for any other procedure, because it's not like they're having an active thrombus. It's a microthromba in the small blood vessels. So far, I think Coumadin, that's the story with Coumadin. Other general measures, so we talked about digoxin, we talked about diuretics. Diuretics is we use it as needed. I think I have one slide we'll go over. And then anticoagulation. The other things is exercise. Exercise has been shown to be beneficial in these patients. There is a meta-analysis from Italy which showed that exercise improves 6-minute walk distance by 100 meters. But all these approved therapies have been shown to improve only 40 meters. So exercise can be as good as these approved therapies. So we try to send them to pulmonary rehab. Cardiac rehab is not approved because they don't have heart failure or they don't have STEMI, but pulmonary rehab covers PAH patients, so we send them to exercise program. And then second, the important general measures is immunization. They need to be up to date on the influenza vaccine, pneumococcal vaccine. And the last thing is contraception. Pregnancy is a disaster in PAH. PAH patients are generally women on the younger reproductive age group, and they don't tolerate pregnancy because of the volume overload, the increased stress to the right ventricle. There is a 30 to 40% mortality. So the reason why I'm stressed out today is I have a 31-year-old who's 27 weeks pregnant with mild PAH. So it's just not a good thing to have pregnancy. So we try to do, contraception in all these patients. What is the best contraception method? The best is actually, exactly. It is the ideal one, but that's not best because it's practically impossible, right? So what we do is tubal, hysteroscopic sterilization methods or tubal ligation. If not, progesterone-only pills, because estrogen has shown to worsen pulmonary vascular disease. Barrier methods are okay, but they are not effective again. Yes, sir. Yes. So no. So even if it's mild, what happens is like when the RV at rest, it's okay. When you have pregnancy, when your cardiac output goes up to 9 liters, 11 liters, normally your pulmonary vasculature dilates and accommodates this increased cardiac output. But in pregnancy, the blood vessels are remodeled and they lose their vasodilating property, so they can't accommodate. So everything is now, so the right ventricle is under pressure because the PA pressure goes up. And the PA pressure goes up, the right ventricle feels the strain and it fails. And mainly during the peripartum period or the post, peri-delivery, peri-labor time or postpartum period is the worst time. And also there is some concern that the change in the hormonal milieu may be making the vascular remodeling more worse. We really don't know exactly what the mechanism is.
Question on pulmonary rehab. Is it the fact that you're training your muscle and your body to accommodate to this newer cardiac output limit in pulmonary rehab, or what is it about the rehab that actually improves survival? Because I can imagine you're actually affecting, is it the stress effect on the vasculature? How are you getting such a good improvement in walk?
Yeah, so to clarify your question, so there's no survival advantage. We don't know whether exercise improves survival.
What is it about the pulmonary rehab that improves your ability to walk?
So the thought process is it's probably due to skeletal muscle conditioning. And also there is growing literature, there's a mitochondrial abnormality as a basic mechanism for PAH. And that mechanism is not only affecting the pulmonary vasculature, but also affecting the skeletal muscles. So these patients have some kind of a myopathy. And it's controversial. Is it because of the mitochondrial abnormality or is it just deconditioning? But regardless, I think it's the skeletal muscle reconditioning which is making them walk. So that's the problem with 6-minute walk test is if a patient gets better, all these drugs were approved based on 6-minute walk test. We really don't know whether the drug is altering the disease course or we're just conditioning them. And, if you talk to people who are initially in the field and how this drug was approved or 6-minute walk test was taken as an endpoint was, people were dying left and right. And they just wanted something. And they wanted the bar to be very, very low. So that's why they went to 6-minute walk test. Now the field has moved. And we are now following the left heart failure and going to a combined morbidity mortality endpoint. None of the clinical trials are 6-minute walk tests anymore. So I would say the short answer is more skeletal muscle reconditioning. Okay, so once these are all the general measures are done, how do we decide our PAH specific vasodilator therapy? So, and I'm stressing the point vasodilator because the currently available therapies don't have any anti-proliferative effect. They are not like anti-cancer drugs. They don't inhibit the smooth muscle proliferation. They vasodilate, they bring the pressure down, they don't cause reverse remodeling. They don't make the proliferative arteriopathy back to normal. So that's the problem in this field. That's why we're not seeing significant survival benefit with these drugs. Okay, so these are the 4 or 5 groups of drugs we have. Simple calcium channel blockers. We have prostacyclins, endothelin receptor antagonists, PDE5 inhibitors, soluble guanyl cyclase stimulators. First is calcium channel blocker. Similar to Coumadin, in patients with idiopathic PAH or familial PAH, a very small subset of these patients respond to calcium channel blocker. And the idea is for those patients, it's not a big proliferative vasculopathy, it's just a vasoconstriction. And if you vasodilate them, their pressure actually comes completely normalized. How do we find out who is a vasodilator or not? And right now, the standard of care is to take them to the cath lab. At the time of diagnosis, you give them a vasodilator. Calcium channel blockers are like when it was first discovered or invented, they put a Swan-Ganz catheter, they'll give calcium channel blocker, they keep them in the unit for 24 to 36 hours, see the response. It's not high throughput, right? You cannot keep doing it. So over time, what we found out is like people who respond to inhaled nitric oxide or IV prostacyclin behave the same way to calcium channel blockers. So we give nitric oxide here. Some other labs uses IV prostacyclin. The other thing to do is IV adenosine. All 3 drugs have been approved. And what we do is we give them for 5 minutes, 8 minutes based on the lab and see whether they drop their pressure. Based on retrospective analysis, the community has accepted the following criteria as a responder because they went back and looked who really did well, and people who met these criteria really did well on long term. That's how they came up with these numbers. It's a 600-patient study from French group and also some from Stuart Rich combined. So how do you define? The mean PA pressure has to drop at least by 10 millimeters, and after drop, the absolute value should be less than 40 with increased or unchanged cardiac output because nitric oxide can have a negative inotropic effect on your contractility. So if you give nitric oxide and the cardiac output goes down and the PA pressure drops, that's not a response. We want a response by vasodilating the vasculature. Okay, so classic example, patient yesterday had 52 mean PA pressure at rest. If I give nitric oxide and she was a responder. So I gave nitric oxide from 52, she came to 33. So her absolute value after nitric oxide is less than 40, and she dropped by close to 20 points. So she is a responder. Now, am I going to treat her with calcium channel blocker? The next thing is I look at her cardiac output. Did her cardiac output go down with nitric oxide? No, it did not go down. So it actually remained stable. The only reason I won't, and the next thing is you look at how sick they are. If they are functional class 4, they're passing out, they're extremely sick, we still don't give them calcium channel blockers. We go to the more aggressive therapy. Yesterday's patient, I'm not going to give her a calcium channel blocker, although she met all the criteria because she's scleroderma. Scleroderma patients have a very malignant course, very aggressive disease. So this is mainly for idiopathic PAH. So it's a very, very small subset of patients. It's still useful to do this test on every patient we see because the prognosis you can see here is these are patients who are treated with calcium channel blockers. On the top line is those who responded, and the other lines are those who did not respond. It's a huge difference. People who respond, it's a different beast. It's a different animal. They have a 95% or 5-year survival, which is unheard of in PAH. So we don't want to miss those patients. And it's much cheaper. Yes, ma'am.
Go back to the second criteria. So let's say you start at 42 and it goes to 39, that's considered?
No, you have to drop at least by 10. So 42 means you have to go to 32.
Oh, so you have to
All 3.
Okay, so if you go just from 60 to 45, that is not.
No, you're right. So exactly, you're right. They have to meet all the criteria. So one of the common questions, even some of the PH experts outside the academic centers ask is, I don't see this quite often. Why am I doing this? Why am I spending money? But having seen patients like that, it is worth doing it because once you identify that subset and you just treat them with calcium channel blockers, it's inexpensive, it's simple, and I've seen patients on calcium channel blocker completely normalizing their PA pressure after 20 years continuing the same response, followed, by the University of Chicago. So it is worth doing it. As I said, it's a very small proportion, But these patients need to be closely monitored, make sure they are sustaining their response, because if they are not sustaining, you upgrade them to the next therapy. Now, we don't want to willy-nilly start calcium channel blockers on these patients. That's what we saw when we did our registry is 10% of patients who were referred to us were already on calcium channel blockers. It doesn't mean that the physicians are doing, purposefully wrong. They are desperate, right? It's a bad disease. They see a young 32-year-old having this disease. They don't have access to these drugs. So what they do is they start them on a calcium channel blocker. It's actually a problem because if you have, like let's say, somebody who has severe RV dysfunction, okay, from PAH, their index is 1.5, and you're giving them a negative, you can give either nifedipine, what are all the calcium channel blockers used? Nifedipine, amlodipine, and cardizine. And if you start them, amlodipine and nifedipine is okay, they don't have a negative inotropic effect, but if you start them on cardizine with an index of 1.4, you're asking for more trouble. Okay, so I think it would be safer not to start somebody on a calcium channel blocker empirically and refer to advanced center if we don't know. Okay, so these are the three pathways right now. All these therapies are based on endothelin pathway, nitric oxide pathway, and prostacyclin pathway. So this is actually this is the lumen of the blood vessel. It's a cross section of your pulmonary artery. This is the endothelial cells, and then this is your smooth muscle. These vasoactive substances are produced in the endothelium. They go into the smooth muscle and act on the smooth muscle. So what does endothelin do? Endothelin goes and binds to these receptors A and B and actually causes vasoconstriction and proliferation. What does nitric oxide do? Nitric oxide stimulates CGMP. We all know this CGMP is, it causes vasodilation. That's why nitric oxide was CGMP was called endothelially derived relaxing factor, right? So nitric oxide. Now, the next pathway is prostacyclin pathway. Actually, prostacyclin, what it does is it acts on the CAMP and causes vasodilation. It causes relaxation again and anti-proliferative effect. So nitric oxide and prostacyclin are good, and endothelin is bad. So in PAH, we know that I showed in the previous lecture that there is increased endothelin and there is decreased nitric oxide and prostacyclin. So let's go one pathway after the other. First, let's say prostacyclin pathway, because that's the most effective pathway. So these patients are deficient in prostacyclin, not systemic, in the pulmonary vasculature, in the smooth muscle of the vasculature. But if you give them systemically, it'll reach there. How can we give prostacyclin? So when I first started, there was only one way, parenteral prostacyclin. But now we have several ways of giving prostacyclin. So one is parenteral prostacyclin. Intravenous, continuous infusion pump, or subcutaneous. Instead of intravenous, the same pumps can be given subcutaneously. Second, you can give them inhaled. It goes into the alveoli and then goes into the pulmonary artery, but it's not going to be as effective like an asthma inhaler, but still the drug reaches the pulmonary artery smooth muscle cells. Then you can give oral prostacyclin. Then now there is actually a prostacyclin receptor agonist just approved January 4th called Selexipag or Uptravi. It's not a prostacyclin, but it goes and binds to a specific prostacyclin receptor called IP receptor. There are multiple prostacyclin receptors. IP is the one which is in the smooth muscle of the pulmonary artery, and this one goes and directs that. Okay, I'll go over one after the other. Out of all these things, if somebody is like the most effective therapy is parenteral prostacyclin. That is the only drug which is shown to improve survival in this patient. All these other fancy drugs improve 6-minute walk distance, reduce hospitalization, but none have shown to improve survival. So this is the data, actually the old data, 1996, on epoprostenol, which is an IV prostacyclin. So if you give this drug, within 12 weeks, there was a survival advantage, which is a short time. That means the drug is really effective. Is it okay if I take this? Hello, technique. Hi, Tiffany. I'm in the middle of a lecture. Is there something urgent? Okay, thanks. Sure. That's right. So, yes, sir.
We're not talking about responders,
These are non-responders.
These are non-responders.
So once you do the vasodilator testing, and if they are responders, you go on the calcium channel. But if they are not responders, then you start thinking about the PAH vasodilator therapy. I have an overview slide. I'll show you how we approach that. So these are non-responders.
That's how they set studies.
Exactly, these are non-responders. So these are people who did not respond to calcium channel blockers, so they gave them epoprostenol. And in 12 weeks, people who did not get died significantly, there's a survival advantage. Now, yes, sir.
Is there an issue with the inhaled mechanism in the same way that asthmatics, they have an issue with having the proper respiration?
That's true. That is true. It is it's cumbersome, number one. It's 4 times a day, and they have to take a deep breath in to get the drug in, and it's not as effective as the parenteral prostacyclin. The drug concentration, when it reaches the pulmonary artery smooth fluid, is very low. So that's why these drugs don't have side effects. But when they don't have side effects, that means they are not being very effective. So, but life is always a yin and a yang, right? Otherwise, it would be very easy. So if this therapy was the most potent therapy, and if it's very easy, then it will be easy, right? No one would worry about PAH. But the problem is parenteral prostacyclin is a complex procedure, right? It's a big lifestyle change. So normally, what we do is we do a single lumen Hickman catheter. Why a single lumen? We always get a call when a patient gets admitted. Why a single lumen Hickman catheter? Because we don't want a double lumen. When there's a second lumen, human mind is always tempted to use that second lumen. They go to a local ER, they want to have a blood draw, the ER nurse flushes it. When they flush it, the patient gives a bolus dose of prostacyclin, blood pressure drops, they pass out. Okay. And we don't want, and then if they do something else with the line, and if the line doesn't work, these are short-acting medicines, then you are in an emergency situation, especially with epoprostenol. So that's why we do a single lumen catheter. So we do a single lumen catheter, and then I think I have one more slide. I don't think I have. So, and then this is called a CAD pump. The lower portion of the CAD pump you can see here is the cartridge. So basically what it involves is the medicine comes in a powder form, and they send a diluent. So the patient takes the diluent, mix it with the powder form, makes a liquid form of the medicine by themselves, sterile, fill the cartridge with a syringe, and then they connect themselves to this catheter. How often they do this? Based on how much drug they are getting and what is their dose. Usually they change the cassette once in 2 days. Every 48 hours they keep changing. Is it impossible to do? No. Definitely it's not convenient, but once you learn it, it's easy. I have an 18-year-old who doesn't speak any English, who came from Kenya 2 years ago. Everybody was reluctant to start it because it was the most effective therapy. We pushed and started it. She's doing phenomenal. She's in school. She's going to go for college now. She learned it. And I have a 79-year-old from Hibbing who nobody was willing to start it, and I started it, pushed it. She's doing great. She's functional class 2 now, and she's doing it. So, but at the same time, I have a 35-year-old who doesn't want to take care of it. Comes out every time. So if you are willing and you wanted to do it, you can do it. Okay. So just for time's sake, I'm just going to skip this. Now the other way of delivering this is subcutaneous. Okay. We have 2 prostacyclins, parenteral, right? Epoprostenol or treprostinil. What is the difference between these two? Epoprostenol is the most potent molecule because that's the one which is shown to have survival advantage. Okay. But it's a very short-acting molecule. It's only 5 minutes half-life, so it has to be given intravenous. It's not stable in room temperature, so people have to carry ice bags on top of the pumps here. They have overcome that problem. There's a newer molecule called Validri, which is a brother of epoprostenol, which is stable in room temperature, but still short-acting. It's only 5 minutes. What happens is if the catheter doesn't work for 10 minutes, if the patient doesn't get the medicine, they can have rebound pulmonary hypertension, and they can cause RV failure and cardiogenic shock. So that's the problem with epoprostenol. The other drug is treprostinil or Remodulin, is long-acting, relatively 3 hours, so and stable in room temperature, so it can be given subcutaneously. So the alternate way of doing it is subcutaneous. Remodulin can also be given IV. So we use most of the time here IV Remodulin because people are living in Hibbing, they don't even have a close ER right now, close to their home, so that's why we prefer to use remodeling here. Now, what is the problem with sub-Q? Sub-Q, the problem is 80%, like, this is a different pump for sub-Q. It's called CAD MS3. And you can see here, this is the biggest problem. If you take 10 people, 8 people, 80% of them develop side pain, erythema, and induration. They just can't handle it. So they will switch to IV. So I was not trained with sub-Q, so I always try to go IV. There are people on the southwest, LA, who swears that sub-Q works for them. 80% of the patients are on sub-Q. They don't have any line infections at all. So it also depends on where you train and how comfortable you are. But at least in my experience, the side pain is a huge problem, and they have to keep changing every week. So we prefer not to do that. Yeah, that's fine. So this is data. This is from IV remodeling. So remodeling can also be, a treprostinil can also be given intravenously and subcutaneously. What does it do? It is shown to improve 6-minute walk distance in these patients. And you can see the difference here, like week 4, right? Yellow is remodeling, and gray is placebo. From 50 to 80, it's only 32 meters. If you really look at it, people say, how much you go through for this 32 meters. But this is 4 weeks. And they are at a relatively low dose when the study was done. In real world, what we do is we keep up titrating them to a higher dose, so they have a much significant increase in their 6-minute walk distance and their overall quality of life too. So what are all the problems with prostacyclin? Not only the complex delivery system, it also has side effects. The prostacyclin causes vasodilation not only in the pulmonary vasculature, right? You're giving it systemically, so it's going to make you have flushing. They'll be red as a beet when they come to you. They have headache. They have diarrhea because of GI vasodilation. They have the classic thing called the jaw pain. When they eat for the first time, they have the jaw pain. They have leg pain, heel pain because of vasodilation in the bone. It can cause hypotension. It can cause dizziness. It can cause syncope because of low hypotension. And if it's inhaled, which I'll show next, is cough. And delivery site complications. If it's sub-Q, they cause side pain. If it's IV, catheter-related infections like pacemakers and stuff. So to avoid this pattern of prostacyclin therapy, so they said, okay, let's try inhaled therapy and whether it's effective. So we have 2 drugs in inhaled. One is called Ventavis or Iloprost, which is 7 times a day. It's very cumbersome, so people don't use it at all. It's kind of obsolete now. So the other drug is the same treprostinil or remodeling comes as an inhaled one. It's a 4 times a day dosing. You take 9 breaths to 12 breaths. You start at like 3 breaths, gradually increase it, go up to 9, up to 12 breaths, 4 times a day. The most important side effect is just cough. It's not systemically absorbed, so you don't see any systemic side effects. But at the same time, it's not a very potent drug. It also has shown to improve 6-minute walk distance at week 12. This is how the trial was. Actually, the drug was approved based on a trial called Triumph trial. Patients compared to placebo at 12 weeks, there was a 20-meter improvement in their baseline 6-minute walk distance. So we talked about parenteral, we talked about inhaled. Now, more recently, 2 years ago, we have this molecule called oral treprostinil, which can be given orally. It still has a lot of side effects. It's a GI side effects, nausea, vomiting, hypotension, but it has been shown to improve 6-minute walk distance as well. What is interesting is this drug has been shown to improve 6-minute walk distance only as a combination therapy, not as a monotherapy. This is again to show that these drugs, the oral and inhaled, are not as effective as the IV therapy. As I said, the most recent drug on this group is called Selexipag. You'll start hearing this name. It's called Uptravi, and this is an IP prostacyclin-receptor agonist. This is one of the largest trials published in the PAH literature so far, 1,000 patients. It's an event-driven trial. It is not a 6-minute walk distance at 12 weeks like the prior data I showed. And Selexipag, compared to placebo, actually improved or decreased combined endpoint of morbidity and mortality. But if you just look at mortality alone, there is no difference. So the drug helped in preventing the people from getting into the hospital and getting worse, but they did not prevent them from dying. So there is no survival benefit like IV epoprostenol with this drug.
What's the mortality in the trial?
The 1 year mortality, so I have to go back and look what is exactly like, because we know the combined morbidity and mortality is a 50% reduction, but the mortality alone, I don't know. I have to go back and look.
Curious, how were they able to do these studies? I mean, how is it ethical?
It's a very, very,
15, 20 people on placebo when we know there's.
it's a very good question. The study was started 5 years, 6 years ago. At that time, not many options were available, but still there was oral therapy and IV therapy. But majority of the patients in this trial were enrolled from rest of the world, not from the United States. So it's from China, South America, Eastern Europe, where these drugs are not available. These patients are actually dying. So those are the patients who got enrolled with placebo versus placebo. And also, patients can be on background therapy if they can, if they are. So they are allowed. They can be on one drug. Yes, yes, yes. Actually, to be very precise, for this trial, 80% of the patients were still on background therapy. But 20%, you're right, were not on background therapy, and some of them were randomized to placebo, and those were from rest of the world. No, oral therapy. They were on the previous endothelin receptor antagonists or PDE5 inhibitors. I don't know Selexipag yet, but it's not going to be very cheap. You know, we haven't used it, just got approved. I was not part of the clinical trial. Roughly it's going to be $120,000 a year. It's fine now. So there is a selective patient population who we may use it. So for example, we start them on an oral drug like PDE inhibitors that are endothelin receptor antagonists. They are not getting better, but they are not extremely sick enough to go to prostacyclin. For those patients, we may try this. But this is not the drug for somebody who is sick, at least in our mind at this point.
Any reason that they were Selexipag over Orenitram?
Yes. So that's a good question. So we have to use the drug and see. Orenitram has not been a great success. We have had problems up titrating the medicine because of GI side effects. We can go only to a low dose where you don't see a clinical benefit. This Selexipag is a specific IP receptor antagonist. The side effects is theoretically low, but still in the trial, patients got actually side effects, GI side effects. But what they did was when they did a GI side effect, they stopped them at the dose. And even in that low dose, whatever they tolerate, there was a benefit. So basically, the idea is you're saturating the receptor. So whatever the dose even if it's a low dose, that may be enough.
We don't really have any knowledge of how the common
The only thing we know is 80% of the patients who were on this trial were on background therapy on these drugs, so it definitely adds benefit on top of the drug. When they did a subgroup analysis and said, okay, is the beneficial effect seen even in the patients who are already on a background therapy? Yes, it does. So there is some data to go behind, but that's not the primary endpoint. So then the next pathway that we right now target is called the endothelin receptor pathway. So basically, you block the endothelin receptor. Under that, you have a non-selective blocker, either it's called bosentan or macitentan, or you selectively block endothelin A, because endothelin A is the bad one. B actually causes vasodilation. So if you can selectively block endothelin A, that's advantageous. When the first molecule, bosentan, came, it's a non-specific blocker. But now they have more specifically blocked endothelin A, the two drugs we have. So the non-selective is bosentan and macitentan. The selective one is the ambrisentan and citaxetan. Citaxetan is not available in the United States. So bosentan, you'll hear about Trochlear. Macitentan is Opsumit. Ambrisentan is Lettiris. So those are the drugs. Again, this is just to show you. I'm going to quickly go through them because it doesn't really matter. Compared to placebo, these drugs have shown to improve 6-minute walk distance. You can see previous trials, 16 weeks, short-term trials. Again, the other drug, ambrisentan, compared to placebo, you can see in both doses there was a significant increase in 6-minute walk distance, short clinical trial, 12 weeks. Macitentan is the other drug which is recently approved, so it's not a 12-week trial. It's not a 6-minute walk distance. It's a combined endpoint. And, you can see compared to placebo, macitentan decreased combined morbidity and mortality again. More specifically, there's no difference in mortality. It's mainly morbidity. What does it do? It prevents them from getting hospitalized, prevents them from getting worse with increased diuretic dose. It prevents them from going on to IV therapy. But it means a lot, but it's still not a survival advantage.
Why that over bosentan?
Very good. So bosentan is it's a twice-a-day drug. Macitentan is once-a-day drug. It has much more affinity than bosentan. It's a newer molecule. Bosentan has increased liver toxicity. Macitentan does not. Bosentan can cause more fluid retention. Macitentan does not.
That's a lot more expensive.
No, they're pretty much the same. Bosentan and macitentan are the same price.
Okay.
So how do these trials actually account for the RV function?
So it's a good point. None of these trials actually looked at RV function. They are starting to look at RV function because cardiac MRI was not the big thing in PAH 5 years ago. These trials were started 5 years ago, so when they designed it, they did not have cardiac MRI. They just did it RV by echo. They did have NT-proBNP, and they did not check in the macitentan or Selexipag trial, but people are trying to incorporate RV biomarkers in the trial, MRI being one, NT-proBNP being the other one, which are easily feasible to do. It's a very good point. They completely, the industry ignored that. So what are all the problems with the endothelin receptor antagonists? They cause nasal congestion because they gain some vasodilation. Abnormal liver function test, mainly for bosentan, so you have to check their liver. It has a bone marrow depression effect, so it can cause anemia. It causes fluid retention, and it's contraindicated in pregnancy. It has a teratogenic effect. The last pathway, right now we target is nitric oxide pathway. So what nitric oxide does is nitric oxide is produced, endothelial-derived relaxing factor. So it's produced in the endothelium. It diffuses into the smooth muscle. It goes and acts, it stimulates CGMP. And CGMP, it helps to stimulate CGMP. CGMP is being metabolized by PDE5 inhibitor. So what we do is to augment CGMP, we go and inhibit the phosphodiesterase 5 so that like the CGMP formed by nitric oxide is not being degraded. You got it? So basically we're augmenting the CGMP. That's by PDE5 inhibitors. The other way to do that is there is an enzyme called guanyl cyclase stimulator. Guanyl cyclase is an enzyme which makes CGMP, so you can go and stimulate that enzyme. So either you inhibit the degradation or stimulate the synthesis of CGMP, so you basically increase the CGMP level in this tissue, smooth muscle cell. So PDE5 inhibitors, you all know about Revardio, Sildenafil. The dose approved is 20 milligram 3 times a day. Why? Viagra is 25 milligram, but Revardio for PAH is 20 milligram. Why? Marketing issue. They just want to make more money. That's it. So it's Revardio is like specific name for PAH. It comes in 20 milligram, but now it's off patent. It's generic drug. It's cheaper now. The next drug is Cialis. Instead of Cialis, they market it as Adcirca, 40 milligram. Again, marketing issue just to make money, and you give once a day. Again, just show that this is Revardio was approved in 2005. Short-term trial, 12 weeks. Primary endpoint was 6 minutes. You can see compared to placebo, all 3 doses improved the 6-minute walk distance. At short term, there was no difference between these 3 doses, but on the long term, there's a follow-up study called Super 2 trial, which showed that indeed, if you give high doses, the 6-minute walk distance increases. There's a dose response. So we tried to go up on the Revardio as tolerated on these patients. This is again to show that for Tadalafil, it increases 6-minute walk distance. What are all the side effects of PDE5 inhibitors? If you start them as patients, they can have nosebleeds, nasal congestion again, headache because of vasodilation. People develop dyspeptic symptoms, flushing, diarrhea, visual changes for any PDE5 inhibitors. Obviously, they're contraindicated with the use of nitrates. In the last group of drugs are called it's called soluble guanyl cyclase stimulator, and the drug is called Riociguat. As I said, it goes and stimulates this enzyme called guanyl cyclase, which makes CGMP. So it also acts on the nitric oxide pathway. And that has also shown to improve 6-minute walk distance. Same short-term trial.
That
Is it, theoretically, yes, both PDE5 inhibitors and Riociguat has been thought to have an RB inotropic property because it not only increases cGMP by a reflex mechanism, it actually also increases CAMP in the cardiac muscle, so it has inotropic property. Nobody has studied it. We looked at, it's very difficult to piece out, when the RB function improves, is it a true inotropic property or is it because the afterload is lower and the RB is improving? So we have to do a pressure volume loop to look at the RB contractility itself, and practically it's not possible. We actually did a small poster looking at RB stroke index, and PDE5 inhibitors include RB stroke index, but it's difficult to publish it because everybody would say, hey, it's because of vasodilation. You can't say that this is coming from just an effect on the RB. But theoretically, at least in animal models, they have done what is called an isolated Langendorf model. So you take a Langendorf model, stick a heart, the right ventricle, and see whether this drug increases contractility. That takes the pulmonary vasculature out of the picture. And in that model, these drugs have shown to improve RB contractility. The side effects are pretty similar because it's the same nitric oxide pathway, vasodilation. So headache, dizziness, dyspepsia, nausea, vomiting, diarrhea, all those common side effects. One thing between PDE5 inhibitors and CGE stimulators are teratogenic. They are not indicated, they're contraindicated in pregnancy. PDE5 inhibitors can be given. So if this girl today who we are capping has severe PAH, I may have to start her on a PDE5 inhibitor or prostacyclin.
How is that?
Oral drug, I'm sorry, it's all oral drug. Okay, so the most recent, because of time, so the most recent paradigm shift in PAH is called combination therapy. Okay, so far what we did was we will give one drug, endothelin receptor or PDE5 inhibitors, based on patient profile. We talked to Dr. Pritzker, he would say he will flip a coin and decide, which is true. Like there is no real guidelines to just say which one to do. So based on the patient profile, we choose one, we give them for 3 months, see how they respond. And if they don't respond very well, then we add a second drug. That's called sequential combination therapy. You add them in sequence. But now this trial, 5 years ago started, said we're going to do upfront combination therapy. Like the lady I diagnosed yesterday, just said give both the drugs, 2 oral drugs at the same time and see how they do. And as you can see, compared to pooled monotherapy, this combination therapy, there was a 50% relative risk reduction in combined morbidity and mortality. Again, driven by morbidity, not mortality, but this is a huge difference. And this is not a 6-minute walk distance, event-driven trial, long-term trial. So based on this trial, in this trial, what happened was there were 3 arms. One arm just had got an endothelin receptor antagonist. The other arm just got a PDE5 inhibitor, and the third arm got combination. Compared to all 3 arms, you pool the 2 monotherapies, or just you take ERA alone or PDE5 alone, you combine these 2 drugs, it's more efficacious. Thought process is why? Why does this happen? There are some people who respond to PDE5, some people who respond to ERA. We don't know who they are. There is no biomarker to identify. We don't have pharmacogenomics data yet. They're not, so there's no pharmacogenomics data to guide us. So if you combine them both, you're just covering most of the patients who would respond. So that's the thought process. We don't know. So right now, I think anyone who has severe PAH, if they get started on a therapy, they're going to be started on a oral. Okay, now, so how do we decide whether we go, we have these 12, 13 drugs I discussed, how do we decide which one we're going to choose, right? First is we decide whether they are low risk or high risk. What are the things we look for? We look for, do they have overt RB failure? If they have RB failure, they're high risk. How quickly they are progressing? Rapid means they're high risk. If they have class 4 symptoms, they're high risk. What is class 4? You know what is class 4, but syncope is considered as class 4. When somebody is passing out, that's class 4 in PAH. It's like aortic stenosis. If their 6-minute walk distance is less than 300 meters, if their cardiopulmonary exercise testing is less than 12, that means they're significantly limited. If their NT-proBNP is significantly elevated. If their PCO2 is less than 32, that means they are dyspneic, tachypneic, they are hyperventilating. On the echo, if they have pericardial effusion or their RV function is significantly reduced. Their TAPC is less than 15. Or when you do a hemodynamic study, if your right atrial pressure is very high and cardiac index is low. So what matters is how the right ventricle handles this. If your cardiac output is preserved and your right ventricle is, right atrial pressure is low, that means you are compensated. Okay, we call it as RVPA coupling, that the RV is able to handle that. In that case, you are low risk. Okay, if you have all these other features, you're high risk. If you're high risk, we go on parenteral prostacyclin therapy. In addition to the simple risk stratification, there are actually two calculators developed. I don't know whether this will go in. Oh, it does go in. This is formula we developed when I was as a fellow. This is a paper I published. So if you, for example, yesterday patient, I did a mean PA pressure of 52, a right atrial pressure is 6, the cardiac index was 2.5. This will give you for survival. For 1 year survival is 93.5. For 2 year survival, so based on this, you can decide whether you're going to go IV or oral based on how poor the survival is. So the other one which is developed is by the REVEAL registry, and it's a little bit more complex than what we developed, but that's also a pretty good score. We can use it to say whether they're group 1, what comorbidities they have, what is their functional class, vital signs, 6-minute walk distance, BNP, blah, blah, blah. You put this thing, you have a score, and then you say low risk, average risk, moderate risk, high risk, or very high risk. So based on that, you can also decide how sick they are. Okay. So this is the summary slide. So when a patient gets diagnosed, we decide on anticoagulation, diuretics, oxygen, digoxin. This is supportive care for most of them. We then do a vasoreactive testing. If they are vasodilator response, they go on a different arm. We treat them with calcium channel blockers and then see response. This is for idiopathic. If they're not a calcium channel responder or non-idiopathic, then we decide them whether they are low risk or high risk based on these measures. If they are high risk, we try to go with parenteral prostacyclin. It's as simple as that. Okay. You can also give oral therapies, but the ideal drug is parenteral prostacyclin. If you are low risk, then you go with oral therapy. Previously one drug, but now we're going to go combination therapy. Once you do combination therapy and you follow them, if they are not responding, then you add a drug, third drug. That's where we may add this newer inhaled therapy, or we add the Selexipag, the new drug, or the oral prostacyclin. If they don't respond further, they go to parenteral prostacyclin, okay, from oral therapy. Now, if you're already on parenteral prostacyclin and you are declining, you need to be referred to lung transplant. When you're waiting for a lung transplant on the list and you're getting worse acutely, atrial septostomy can be done as a bridge to transplant. Or if you're not a candidate for a transplant, it can be done as a palliative procedure to 5, 6 months or 1 year. How does atrial septostomy works? You basically create an AST. And how does that helps? Because you're having some cardiac output to the left side. Basically, blood is shunting from the right side to the left side. You're compromising your oxygenation. Your oxygenation will go low, but at least you're alive. It's Eisenmenger physiology. People with Eisenmenger physiology live. You don't want to do that if they are already extremely hypoxic and their right atrial pressure is very high, more than 20, because if your right atrial pressure is very high, you're going to shunt a lot of blood and you're going to get more profoundly hypoxic and the patient is going to die on the table. So we don't do it if their right atrial pressure is extremely high or if they are very hypoxic to begin with. Lung transplantation is the ultimate cure for these patients, but unfortunately, not many patients with PAH get lung transplant because they are very sick by the time they come, and their right ventricle, then there's this dilemma of, do we just do a double lung transplant or do we need to do a heart lung transplant? What is the line when you can just do a double lung and the heart will recover? It's a gray zone. So many surgeons, small programs are very conservative and they don't want to do it. So as you can see that the number for PH is extremely low. IPH is the pink, magenta color is extremely low.
What pressure do you allow your RV diastolic pressure to reach in relation to the map or your systemic diastolic pressure for RV? You know, how, when you're seeing these patients, when do you start getting
nervous?
Getting pretty close. Getting high. What's your comfort zone, or when do you kind of say that's too much?
we at least would like to have your systemic pressure at least 10 millimeters of mercury above your PA pressure,
In MAP or diastole or what?
systolic pressure.
Systolic pressure?
So, for example, if a systolic PA pressure is 90 and patient's systemic pressure is 85, you are in big trouble.
But most of your coronary filling is done during diastole.
So I don't have a slide, but I'll show it to you.
Much in RV.
No, you are right. Yes, in a normal LV, most of the diastolic filling is done in diastole. Whereas in an RV, it's done both systole and diastole. Whereas in PAH, because of the hypertrophy and pressure, it becomes mainly diastolic. So there is decreased supply, and there is an increased demand because you have RVH. So your RV is more for ischemia. So I think I have those slides. I think Scott is waiting, so I won't put it on his.
So, just going to the next question. So, if you have a oral phase restricted, such as nitrogen, so those patients die by RV failure at the end because of hyperperfusion of the RV. So, just keeping the pressure high with the use of nitrogen, is there any data to support that?
There's no data to support it, but clinically we use it most of the time. I use it like I use my midodin to just bring their blood pressure up, at least to push their prostacyclin. I do it. And when they are acutely ill, when they are in RV cardiogenic shock, we start them even on phenylephrine just to bring the blood pressure up. It has been shown to actually improve. It's never been published, because it's only a few centers who does it. Here's the
Great talk, by the way. Patients who actually get a lung transplant, actually do well, do they get pulmonary again? This is like a pathophysiology of, that is outside the lung?
It's a very good question. No. If they get a double lung transplant, they don't get residual pulmonary arterial hypertension. What has been reported very rarely, sometimes you get a normal, single lung transplant, you leave one native lung, you take one lung out and put a new donor lung. That donor lung sometimes can develop PAH like physiology. And thought process is because this lung is diseased, most of the cardiac output is going through this one lung, and a high output induced vascular changes. But if you really do a double lung transplant, the new lung has not been reported to develop PAH, because the problem is a genetic mutation affecting the pulmonary artery smooth muscle cells, right? It's not like a systemic mutation. It's like mutation on the smooth muscle cells. It's called CMPR2 mutation. That mutation is very focused, at least in familial, and it's focused on pulmonary artery smooth muscle cells. We don't have enough experience on connective tissue disease and stuff, but even connective tissue disease, double lung transplant has not shown to have recurrence again. Probably. Maybe, because median survival for lung transplant is 50% is 5 years, We don't know. There is actually paper from Vanderbilt which actually looked at peripheral blood, mononuclear leukocytes, and did a genetic profile, and they have found a combination of profiles. So they have found out a genomic signature. So rather than giving an inhaled dilator, vasodilator, you can draw the blood, check for that genetic particular genomic signature, and see whether they're calcium channel blockers or not. But this is on a peripheral leukocyte, so we still don't know that early. But there's something there. We haven't studied it yet. Okay, then I'll stop right there. Perfect.